Hi, good morning. My name is Romeo Bhatia. I'm a student nurse practitioner for United States University, and I will be recording this video on the musculoskeletal system, and I will be uploading this video on the YouTube. And are you giving me the consent to go ahead and record this video?
Yes.
Okay, so in this video, I'm gonna do my hand washing before touching the patient, and I'm gonna start with the hands and the wrist. So first of all, when I'm looking at the hands, I'm checking for the symmetry bilaterally, okay, and I'm looking at my patient's hand symmetrically, checking for any swelling, any deformity, any redness, any nodules, any muscular atrophy, and any joint symmetry. Then I'm going to be palpating the DIP, PIP, and MCP joint when there's the proximal interphalangeal, distal interphalangeal, proximal interphalangeal, and metacarpophalangeal joints. Then we're going to go ahead and move on to the range of motion. This is flexion, extension, abduction, and adduction. Okay, then I'm gonna go ahead and move on to the wrist. When I'm moving on to the wrist, I'm looking for the symmetry bilaterally at the both wrist. I'm looking for any redness, any swelling, any nodules, any joint asymmetry, or any erythema on the wrist, and any nodules. Then I'm gonna be palpating the metacarpal and the carpal joints, and then we are going to go ahead and move on to the range of motion. I've inspected and I have done the palpation. Then I'm going to go ahead and move on to the range of motion, which is flexion, extension, radial deviation, and ulnar deviation. Okay, then I'm going to go ahead and move on to the elbows, and I'm going to be checking the elbows bilaterally, and I'm looking for the any swelling, deformity, any redness, muscular atrophy, any nodules, or any joint symmetry problem. And then when I'm palpating the elbow, I'm checking for the lateral medial epicondyle olecranon and the extensor surface of the ulna. When I'm palpating the lateral epicondyle, and when I'm palpating and if patient complain of any pain, that's a tennis elbow. And if I'm palpating the medial epicondyle, and if there's any pain or tenderness, that's golfer's elbow. And then I will be palpating for the olecranon process bilaterally, and then extensor surface of the ulna. Then we move on to the range of motion, which is flexion, extension, then supination, and pronation. Okay, then we move on to the shoulder. When we are moving on to the shoulder, we are looking for the shoulder symmetry. Okay, if one shoulder is higher than the other, we are checking bilaterally, anteriorly, and posteriorly. We are looking for the shoulder symmetry. We are looking for any erythema, any tenderness, any warmth, any atrophy, any nodules, any joint symmetry problem. And then we can go ahead and start the palpation. We are looking anteriorly and posteriorly for the shoulders. Shoulders are symmetrical. They are not unequal. And then we can start the palpation from this notch. We are palpating the anterior, and then we palpate the posterior after that. When we are palpating the anterior, here's the AC joint. When we are palpating the AC joint, and if there's a pain or tenderness, that's a sign for osteoarthritis. Then we move on to the cricoid process. When we're palpating the cricoid process, and then we move on to the greater tubercle. When palpating the greater tubercle, and if there is any pain, that is the acromial impingement and rotator cuff tendonitis. Subacromial impingement and greater subacromial impingement and rotator cuff tendonitis. Then after that, we can palpate the bicep groove, and we are also palpating for the subdeltoid bursa. So we palpated anteriorly and posteriorly for the AC joint, coracoid, greater tubercle, bicep groove, and subdeltoid bursa. Okay, so there's no tenderness, no complaint of pain noted. After that, we move on to the range of motions for the shoulder, which is flexion, then extension, abduction, and then adduction, and then we move on to the rotation, which is internal rotation. This is external rotation, and this is internal rotation. Okay, and after that we have a painful arc test, which is a specialty test. In the painful arc test, we have the patient abduct their arm, and then when they are moving from 0 to 180 degree, if there's a pain from 60 to 120 degree, that is a sign of tendonitis. Okay, that is a rotator cuff tendonitis and impingement. Okay, go ahead and sit down. We can go ahead and that is so when we did the painful arc test, we checked for subacromial impingement and the rotator cuff tendonitis. Then we did the range of motion of the shoulder. We did palpate. We did the inspection. Now we can go ahead, we did the specialty test, we can go ahead and move on to the head and neck. Can you please come close a little bit? When we are moving on to the head and neck, we are looking for the, we are first of all inspecting, we are inspecting for the symmetry, any joint deformities, any abnormal posture, we're looking at the posture also. And then we will be, after the inspection, we palpate for the TMJ joint, have the patient open their mouth, put the two fingers in front of the tarsus, open your mouth. Okay, there's no tenderness of the TMJ joint, which is temporomandibular joint. And then we're going to have the patient open their mouth and move the jaw side to side. Okay, that is checking for the mobility and any tenderness. And after that we can also palpate the sternoclavicular, clavicle area, cervical area, supracervical area, rhomboids area, and trapezius muscle. So when we're palpating for the sternoclavicular, cervical spine. We're checking for cervical spine, sternoclavicular, palpating clavicular, cervical, sternoclavicular, cervical, paracervical muscles, trapezius muscles, and the rhomboids muscles. So we are palpating for those. Okay. Then after the head and neck, we are gonna go ahead and we do another test where we have the patient open their mouth and they should be able to put their three fingers vertically. And so open your mouth. So that is checking, the if the patient is able to put their three fingers vertically. Okay, so that is checking for the opening and closing of the mouth. And then after that we are gonna do the range of motion, which is a flexion, extension. Then we can move. It's okay. You don't have to change. Lateral, side to side, and then the circular. Okay. So when we did the three fingers, that is to assess the maximal opening. Like this, so they should be able to put three finger vertically. That is checking for maximal opening. Then we did the flexion, extension, lateral, side to side, and the circular motion of the head. Then we have a specialty test, is called the Sperling test. In the Sperling test, we are performing, have the patient turn their neck to the side and like this, and look upward, and the examiner stands behind like here and look upward a little bit, and then examiner put the pressure downward. Okay, and that is checking for the cervical area, for the if there's any pain, any cervical nerve root pain, cervical nerve root impingement. Then we cannot perform this Sperling test on the patient if they have any spinal problem, if they have any spinal injury, if they have any head injury, or if they're elderly patient and they're frail. Okay, so we cannot perform that test on those patients. So after that, neck and head, we are going to go ahead and move on to the lower extremity joints, which are the feet, the toes, and the feet. And then in the toes and the feet, we are looking for, we are inspecting, when we are inspecting, we are inspecting the toes for any swelling, any redness, any nodules, any asymmetry, any tenderness. We are palpating for the Morton's neuroma, interdigital neuroma, and we are checking for any calluses, any corns, plantar fasciitis, and then we also perform the range of motion. Okay, do you flex the, and then okay, and then abduct and adduct. Okay, so I'm going to do this. He did this passive active motion, and I'm going to do the passive. So flexion, extension, abduction, and adduction. Okay, after that I'm going to go ahead and move on to the ankle. When I'm moving on to the ankle, I'm checking for any swelling, any redness, any warmth, any tenderness, Then I'm palpating for the Achilles, lateral and medial malleolus. And then after that we have a range of motion. In the range of motion we do the plantar flexion, dorsiflexion, okay, and then circular motion, ankle, okay, circular motion of the ankle, okay, and then we do the eversion and inversion. So this is the inversion. When the patient move their feet inward, that's inversion, and outward is eversion. So inversion and eversion. So inversion do this, and then eversion, okay. And then we also be doing these motions pass actively. So when I'm doing the plantar flexion, then dorsiflexion, then motion of the ankle, circular motion, okay, and then we did the inversion and eversion. Alrighty, now we're gonna go ahead and move on to the knee area. In the knee, we are looking for any symmetry, any tenderness, any swelling, any nodules, any deformities, and then we are checking the symmetry of the knees, and swelling, nodules, redness, we check for that. And then we are also checking for the alignment, which is the vagus and the valgus deformity. And then we will be we're palpating for the suprapatellar area, sides of the knee, and then we're also checking for the popliteal fossa for the Baker's cyst. Then we'll be moving on to the knees range of motion, which is the, go ahead and stand up for me. This is a flexion, extension, and then the other side flexion, extension, okay. Then we can be doing the another test, which is a valgus varus. Okay, go ahead and lay down for me. Hello for you. We will be having a patient laying supine mostly, and in the valgus test we check for MCL, and in the varus test also we check for the LCL joints. In the valgus test we have the patient lay supine, flex the knee to 20 degree. When we have patient flex the knee to 20 degree, then we have the patient flex the knee to 20 degree. We're supporting the flex the knee to 20 degree. We're supporting the outer lateral surface of the femur and holding the other hand with the ankle, and then we will be abduct, okay. That is the valgus test. And in the varus test we are supporting inside the humor, holding the ankle, and we are doing the, excuse me, adduction. We are adding adduction. So that is the valgus and the varus test. And then we have a anterior drawer and the posterior drawer test. In the anterior and posterior drawer test, we have the patient laying supine, flex the knee to 90 degree. Examiner sit on the patient's foot and holding the leg. We are moving the pulling it posteriorly and pushing it anteriorly, pulling and pushing. So that is for the anterior and posterior drawer test. Then we have Lachman's test. In the Lachman's test we also have the patient lay flat, flex the knee to 20 degree, and we have one hand on the femur, like on the lateral side of the femur, and the other close to the tibial tuberosity. Okay, so in the Lachman test, we have one hand close to the tibial tuberosity and the other hand at the lateral side of the femur, and we are doing the pulling and pushing. Okay. So that is the Lachman test. And then we have a McMurray test for the meniscus tear. In the McMurray test, we are holding the knee, and we will holding the femur area, lateral aspect, and we rotate the tibia medially. We rotate the tibia medially. I don't know if she's able to see. Okay. So in the McMurray, we holding here and this, and we rotate the tibia medially. Okay, and if there's any meniscus or any crepitus meniscus tear, then we will be able to see that. So those are all the tests. So we did the valgus and varus. anterior drawer and posterior drawer, McMurray and the Lachman test. In the valgus test, we are sorry, in the yes, in the valgus test we check for LCL joint, and in the varus test we check for MCL joint, and then we have a McMurray where we move the medially, we rotate the tibia medially, for that is for the meniscus repair, meniscus tear, and we move them medially or laterally. And then another test we had is a Lachman, where the patient is laying angle 20 degree of the knee, laying supine angle 20 degree, and we are holding the lower leg close to the tuberal tuberosity and the upper side lateral aspect of the femur, and then we perform the test by moving the tibia, pushing and pulling on the tibia. So that is the Lachman test. Lachman test, then we did the McMurray. Lachman is for the anterior cruciate ligament. Then we did the McMurray, where we move the tibia medially or laterally for the meniscus tear. Okay, and then we did the knee. Then we have a hips. When we are looking at the hips, we are looking for the hip symmetry. You can stand up, please. We're looking for the hip symmetry. If the one hip is higher than the other hip, we are looking for that. Then when we are looking at the hip, we are checking for the anterior. So we're palpating the hips first of all, palpating for any swelling. We're inspecting. I'm so sorry. We are inspecting the hips. So we are inspecting for any swelling, any alignment, any nodules, any redness. Then we palpate for anterior superior iliac spine, posterior superior iliac spine. We are looking for the greater trochanter or sacroiliac joint. So we are palpating for all those. Okay. Then we are gonna go ahead and move on to the palpation of the spine. Then we have the range of motion of the spine. The hip. We are moving on to the hip. Then we are doing the hip. We are doing the flexion. We are doing the flexion like this. Do this. Flexion. Flexion. Okay. This is flexion. Extension. Then we are abducting. Then adducting toward adding. Okay, and then after that we can have a special test, and I can perform the hip test while you're laying here, because I think they're not able to see us while doing in the standing position. You can lay down. Yes, so we inspected the hip, we palpated the hip, and then we are performing the range of motion on the hip. In the hip motion we are doing the flexion, okay, then extension, and this is abduction and this is adduction. Okay, then we have internal rotation and external rotation. Relax your knee, and this is external rotation, and we're moving this way. That's internal rotation of the hip. Then we have a Thomas test and the Faber's test. In the Thomas test, we have the patient, this is to detect the hip flexion contracture. Then we have the patient bend their right knee and all the way, push it against the abdomen. And so that is for the contracture of the hip. That is Thomas test. And in the Faber's test, we will put the test leg on the other side above the patella. So like this. This is the test leg. We can bend it, put it above the patella, okay, and then while supporting the hip here, we're pushing it downward on the table. Okay, that's for the Faber test, which is flexion, adduction, and external rotation. So that test is for checking the any tenderness of the posterior back. So that's the Faber's test for posterior back tenderness. Then we move on to the spine. Okay, go ahead and stand up. When we are checking for the spine, we are looking at the spine. When looking at the spine while the patient is standing, we're looking at the shoulder symmetry here. We're looking for the iliac crest symmetry. We're looking at the overall spine when the patient is standing. Cervical or lumbar lordosis. We're looking for dorsal kyphosis from the side and shoulder height symmetry and iliac crest symmetry. We're also looking for the creases, which I can show you here. The creases below the buttocks, so they are symmetrical. Then after that, we can go ahead and move on to the range of motion. In the range of motion, we can have the patient bend forward. We see how much they can bend and touch their toes. So when we are doing bending the patient slowly as far as possible with their back to the examiner, we are checking the back for the dorsolateral spine. Okay, we're checking for this any kyphosis, any lordosis, or any scoliosis. Then when we are checking that the curve of the spine is very smooth in my patient, there is no scoliosis, no lordosis, then that's the also checking for the range of motion. Okay, then we can have the patient extend as far as possible, and I'm supporting the back. That is another range of motion test backward, and then we can check side to side. Okay, and then the other side. Okay, then I am go ahead and palpate the spine. When I'm palpating the spine, I am palpating for the spinous process and intervertebral spaces. Okay, checking for intervertebral spaces. Then I'm percussing with the ulnar surface of the hand. Okay, any pain or tenderness, we're checking for that.
No.
Okay, and that's the spine, and I think that's all. We did the head, neck, knee. Oh, there's a special test, sorry, which is a straight leg test. The straight leg test is when patient is laying supine and we have their leg all the way up, and then that is also checking for any pain in the back. So that is for lumbar radiculopathy. If the patient is laying down and then with the supine position, and then we can be moving their leg as much as possible, and if we will be checking if there is any compression of the nerve or any lumbar radiculopathy, okay, or any pain or tenderness. Alrighty, that's all. Thank you so much.